and it was sort of fun putting this talk together. We do have what I think is a pretty good experience with ulnar dimelia, and I want to share some general thoughts, and I look forward to wisdom from the group, as, again, this is uncommon for all of us. So I am in St. Louis, Missouri, which is right in the middle of the United States. We are known certainly for our arch, but we are also known for healthcare. And we have a great academic hospital system, and I'm fortunate to work in two of those hospitals, St. Louis Children's Hospital and the Shriners Hospital. I do want to put a plug in for this meeting. The outline for the meeting is really, really exciting. And there are pre-courses on the Wednesday of the meeting, and the meeting itself is Thursday, Friday, and Saturday morning. Should be a beautiful time of year in Minneapolis, and hopefully you can make it. I assure you it'll be a great experience and a great time. So, ulnar dimelia. We can all appreciate that this is a rare anomaly. I remember one of the first textbooks I owned was The Growing Hand, with Amit Gupta as one of the editors, and there was a great chapter on the search for the growing hand, talking about its rarity and how experience can be gained. In the OMT classification, it is a malformation of the radial ulnar axis. And I've always thought it was a very interesting developmental abnormality. And Dr. Riddle, more than 20 years ago in chick embryos, described transplanting either the zone of polarizing activity or transplanting, or basically taking a pledget of sonic hedgehog, and that can help to create a mirror limb. It's really interesting because I think, as we all appreciate, the ulnar portion of the limb is dependent on sonic hedgehog, and so there's no radialization if you have sonic hedgehog, which is a morphogen from both sides of the developing limb. So really, really interesting. I'm going to just share a few patients to give demonstrations of what a mirror hand might look like, because they all do look different. Sometimes the hand is the clear dominant issue, and sometimes it truly is from the elbow distal. So just a few pictures emphasizing that each of these children is quite different. Typically, as I pan through these, there are 7 or 8 digits. The more ulnar digits, which in this patient would be these 4, are typically more normal, but not always normal. And there often is a divide between those 4 digits and the others. So just a few examples of what a mirror hand might look like. So my generalizations are, again, typically 7 or 8 digits, with the ulnar 4 being more normal. The radial digits vary in number and quality. The vascular anatomy is highly variable, and I'll explain why that is tricky. And functional use patterns are really important to understand preoperatively to help provide the best hand possible. And so, in keeping the surgical principles simple, my goal here today was to provide an overview and hopefully generate some good conversation. I think the primary preoperative goal is to identify the radial digit that the child will use. And it is really a difficult conversation to have with the family if all of those radial digits are poor. And while certainly you could choose to policize one of those poor radial digits, but the child will never use it. And so it is the case that sometimes you take an 8-finger or 7-finger hand and turn it into a 3-finger hand with a thumb. Now, I know there are cultural choices to be made, but from a true functional standpoint, picking the best radial digit to create a thumb is, I think, the single most important thing we do. And you can watch this child. You'll see, hopefully, where the break is, and him, it's a little bit easier, but you can see, and this is a very brief example, that the digit here was clearly the best of the radial digits, and so was chosen for pollicization. At the time of treatment of the mirror hand, I always find flexor tendons to transfer dorsally to help with balancing the wrist. But I will say that this is one of the conditions where I believe early therapy is super helpful. And so most of these kids come in with the wrist at 90 degrees of flexion. Some of them can be passively corrected to neutral, some of them cannot, but early therapy can restore the passive arc of motion. And then at the time of surgery, a tendon transfer can be done. And that can really be anything. If you're removing a number of digits with good tendons, then those tendons can be used to help extend the wrist later. And there are always multiple flexors of the wrist, and one of those can be transferred dorsally. So tendon transfers are part, for me, of the pollicization intervention. And then I will say that vascularity is something that has to be observed carefully. The arterial inflow to the chosen digit to pollicize can be poor. And I've encountered, and I'd be interested if others have as well, I think in almost every child I've done, the second to most radial digit post-operatively in my patients has given me anxious times with a very dark appearance that ultimately always has resolved. And so the first time I saw that, I was very nervous, but as I've seen it regularly, that's less of a reason for concern. So I'll show you, this is just one child where we chose to pollicize and create a four-finger hand with a thumb. I would say that this aesthetic appearance is not nearly as good or as satisfying as we have with a more typical pollicization. And I think you can get really good clinical and aesthetic results, but I'm not nearly ever as happy with this pollicization as I am with a more typical pollicization. Two things also to be noted. One is addressing the wrist, and so I do pin the wrist for 6 weeks, and you can see my tendon transfer recipient site here. And then I pin the thumb, which I do not do in typical pollicizations. I should say I might pin the thumb, which I don't do in typical pollicizations. And so it's about putting the thumb in the best position and holding it for soft tissue healing. So this is that child. Oh, I thought I had a video. Anyways, this is this child at 5 weeks, utilizing the thumb, which obviously is encouraging. And then here's a quick video of the same child incorporating use of the thumb, which again, I think looks okay. I wouldn't say it looks great, but functionally, with encouragement, the child incorporated the thumb nicely. You can see the wrist remains flexed despite the tendon transfers, but in a much better resting posture. I'm going to pivot, and then I think, Dave, if that's okay, I'll pivot and talk about the elbow, and then we can come back and talk about everything. So while the wrist and hand are certainly different, I think the general strategies we use to pollicize apply here. And so the elbow is more challenging, and I think there are less clear principles for care. And the honest fact is you don't have to always treat the elbow. And so it's just less commonly treated even than the wrist and hand and mirror hand. The basic principle of this is that when you have a true ulnar dimelia, you have two ulnar bones, and they are both rotated externally. And so they're not sitting in the normal plane of motion. That, together with muscle abnormalities, limits elbow motion. And like with the wrist, I do believe early therapy is helpful. to improve passive motion, but it can only go so far because of the bony abnormalities. So my generalizations for the elbow in ulnar dimelia, first, there is often an anterior flange or bony buttress, which can block flexion. The more radial of the ulnar bones can be contoured, and I'll share a citation that Taki has provided, which is really good and really helpful when you next address this type of issue. And you can contour this more radial ulnar bone and help both with flexion and rotation. Again, some of this is a challenge because muscle development is poor. And you can consider ulnar osteotomies to rotate that primary ulna differently. But I typically would wait to an older age before I do that. So let me share a case and share what I did, to try to learn a little bit, and hopefully share some of that with you and show what we did intraoperatively. So this was a 12-month-old who traveled from Canada, limited elbow motion, and you can see elbow was pretty stiff, forearm was fixed, wrist was at 90 degrees of flexion, but could be passively extended. There were 5 good fingers with 2 additional fingers, and it was unclear exactly how the child was grasping, but it seemed like 4 fingers and a thumb could be maintained. A couple more x-rays showing and focusing on the elbow, which I think you can sort of get a sense of potentially this being one of the areas of concern. And in this child, the ulnar bones are not exactly symmetrical. You know, they don't look exactly the same, even though they are pretty similar. So I'm going to show you some more information, and this is obviously a quick scan through, which just shows that, you know, this more radial of the ulnar bones is somewhere between a radius and an ulna, where the more ulnar bones is more like truly like an ulna. And then this is a 3D reconstruction, which again shows the same thing and gives you a sense of maybe that anterior flange on this side is more problematic than the other, but gives you a sense of the development of the bones. I thought it would be interesting, and it actually was a bit helpful to create a 3D model for surgical planning. I didn't realize it would be even smaller than the small child. So I next time I know to tell them, make it life size, because it was really small. But it does give you a sense of, again, the bony development and what the surgical goals would be. And so our goal was to maintain this ulnar bone, optimize this one, and maybe I should say radialize, and remove this anterior flange to hopefully help with motion. And this is just, I don't know if I need to show you that or not. 360 view. Here's some clinical pictures of this child, and you can see the hand, 4 pretty good fingers, and it was pretty obvious in this child that that finger would be the one to policize. More of the same. And then it's hard to demonstrate something like this with static pictures. I do have a couple of videos. I have done this with an anterior approach, and I would not do it again. So an anterior lateral approach was our most recent surgery, which was this one, which was maybe 6 or 9 months ago. And I think it's a careful approach given the absolutely abnormal neurovascular anatomy. And so we carefully protected all the longitudinally running structures, which certainly includes what may be similar to a radial nerve, but probably isn't a true radial nerve given the lack of dorsal development, and then approach the joint. And you can get a sense here of the distal humerus, that more radial of the 2 ulnar bones. And then I was curious about the anatomy. Hopefully you can see that. We were tracing this longitudinal structure, which eventually gave some extension of the fingers, but really nothing much of the wrist. And so we were just extraordinarily careful with how we approached this elbow. And then we made choices based on what type of motion we could restore intraoperatively. Again, here was the joint. Here we are removing that anterior flange, and then we also contoured that proximal ulna. Now, I might say that we could have done more. That's always a question of how much can you or should you do. So intraoperatively, you can see that we regained rotation, but here you can also see that there was still a block from that anterior flange to motion. And so we did more work is the bottom line. But I think that intraoperative assessment was very helpful for us as far as what to do more of. And so this is where we stopped. And again, others, and I look forward to the comments of others. Perhaps we could have done more with tapering or contouring this the new proximal radius. We achieved about 100 degrees of flexion, which I was pretty happy with. That doesn't show at all, but and postoperatively, the patients, in my experience, if these are done young enough, patients will continue to improve that motion. And I'll get to my take-home points as far as how I think about timing in just a minute. So this is Taki's paper, which I recommend. I think it's the best thing out there as far as how to think about this. So congrats, Taki. And it really talks about how to contour that proximal radius. And to me, the question always is, how much work do you do? How much contouring are you able to do in a patient like this? And then the muscle, what to do with the muscles is also tricky. We definitely took down some of the radial-sided musculature and transferred it in an attempt to gain more active flexion. But even restoration of passive flexion, as we all know, is really a dramatic improvement for these children. And so my considerations, and hopefully will spur discussion, is that even in the busiest of centers, these are quite rare. It is our philosophy to treat the elbow early. And so early is usually 6 to 12 months. And the concept there is, I believe if we can improve the passive motion, hopefully the active motion, we also allow the elbow to contour and remodel itself. And I think improvement can be seen over time. So I start with the elbow first. And then that gives me a more typical time frame for us is 18 to 24 months for policization. And so that's what I do second surgery. And again, this is not your typical policization. I think the biggest and most important discussion for the family is which digit are we going to policize? So that is all I had prepared, and I look forward to a great conversation.
Thank you, Chuck. That's a fantastic overview, and you've obviously got you've got a whole lot more experience than I have with this, and I'm sure the messages there are really valuable. I think the elbow is fascinating in terms of stability. When you've whittled down that the radial ulnar, do you feel that the ulnohumeral joint, the true ulnohumeral joint, is adequate for stability, or are you concerned about that as part of this?
Yeah, and there are others on this call who I'm certain have experience, including Take, and I know Dan has experience. So I look forward to their thoughts as well. Despite it, what I would call now the true ulna being rotated, I have not had any concerns about its stability, at least in the patients that I have treated, nor have I had concerns regarding that new proximal radius. And so it was a little mobile, but I think over time that calms down. It has not been a source of pain. I mean, in kids, wouldn't hear about it, but hasn't inhibited motion in these children. So I would welcome the perspective of others on that question regarding stability of the joint and stability of the, I guess, new radiohumeral joint.
So Dan, you've got a comment about annular ligament reconstruction?
Yeah, I haven't, Dan, done that. I'm not a big believer in the annular ligament as being an important structure in general. And I, for example, a Beltaw's reconstruction, again, in a different type of situation, has never really impressed me as doing much. I haven't done that here, but I would love to hear if you have and how it's been helpful.
So yeah, I have not operated on these elbows. It's interesting to hear your perspective on this. Generally speaking, the ones that I've seen that look like two ulnas have gotten about 9 degrees of flexion, and I've sort of accepted that. And I was kind of happy with that. But I think what you're showing is that you're getting more than 9 degrees of flexion, which is actually, I think, very helpful. So I agree with you on an annular ligament reconstruction in general. We don't do the bell toss because I feel like it's a non-anatomic reconstruction. What we typically do is we use the biceps tendon, half the biceps tendon that we move from the radius to the ulna on the sort of anterior flange of the PRUJ. And then we take half of the tendon and bring it around. So as Mary Beth talks about having the biceps be a deforming force that pulls up on your proximal radius and taking that out. Do you see a biceps in these kids, or is there no biceps?
There has, it's always, I know we've all experienced this. You want to really explore and really see what's there, as all the original articles on congenital hand would talk about. I don't extend the operation or extend my incisions aggressively to better understand, but I do not believe there's ever a biceps tendon here.
Yeah, I didn't see anything with what you were showing. So I think that's, and the only time, by the way, that an annular ligament reconstruction works if it's a loose in out, meaning it's kind of just, it can go in, it can go out, you can just push it very gently. If you have to force it in, an annular ligament, you need more, you need something bony. That's not going to work. So I think we agree on that.
So Taki, can we get a comment from you about the elbow? You've written about this.
I think I don't need the reconstruction of the annular ligament because still some stabilization of humeral radial joint, because X-ray seems to be the very symmetry, but the ulnar side is the role of the ulnar, and the radial side is the role of the radial side. So not exact symmetrical. So the annular ligament is still there. So it's not do the annular ligament reconstruction. And the biceps tendon is also there, as I wrote the paper and I checked the case of the ulnar dimelia. So
I've got a question. We have a question here. Why do you start with the elbow, which is the more uncertain part regarding a result? And at what age do you do the elbow? I think you said 12 months or the earliest you can. But in terms of that uncertainty and trying to have a winner for these kids first before you do the more tougher bit.
Yeah, I do agree that the hand is a bit more predictable, but maybe not as predictable as you might expect. It is a harder reconstruction than the typical pollicization. But my philosophy is I want to treat the hand at the optimal age for the hand, and that's 18 to 24 months for me. Certainly it can be done younger, but that's when I like to treat those kids, both from a size perspective and also for a potential kind of interacting with the world / therapy perspective. I think it's better when they're a little older. And so families are being asked to be very patient, especially with this degree of an aesthetic appearance challenge. And so they are willing to do the elbow earlier. And again, the reason I like to do the elbow earlier is one, I don't think I'm making any compromises. I think it's sufficiently large and the anatomy is sufficiently well developed to do it at 12-ish months. And second of all, I do believe the earlier you get the elbow moving, the more likely you can have remodeling, which is beneficial to the child. And so for both of those reasons, I like to treat the elbow, and I haven't had regrets about that.
And the longer term follow-up, the results of these kids with your releases, you mentioned before that you think you actually get better movement further down the track.
Yeah, I wish I could be more exact in my response to that. I would love 10-year follow-up or something like that. I don't have it. But my sense is, and the family's perspective is, the elbow keeps improving over time.
Just with respect to the policization, you said that it's harder than normal, and your explanation for that?
There is a great deal, in a typical policization, you sort of understand what the anatomy will be. If that's a 3B thumb, it may be different than if it's an absent thumb, but you pretty much understand what the anatomy is if you do enough of these. And so working with that anatomy is becomes straightforward. In this situation, the anatomy is completely abnormal on that radial side. The vascularity to the digit that you are choosing to policize is, I would say, most typically, this is both what I've read and what I've seen, a single artery and likely a single nerve. And so it's just less predictable. And there's so much stuff that you have to both excise the more radial the digits that you're not policizing. You need to think about saving some tendons to transfer dorsally for wrist extension, and get the best possible policization that you can appearance-wise. And so I found it harder. And I don't know others who have done this, if you agree or disagree, but I found it harder. And there's also, I guess I should say, there is a huge range, and maybe that's even more impressive than a more typical radial deficiency policization, in the quality of the what we have to work with. And so I think what we start with, as we always say, with a policization determines what we end with. And so the quality of the index finger, in my mind, is absolutely the most important factor in the quality of the policized digit. And so that's true here too. And so I don't think we're necessarily dealing with the best possible digit to policize in most of these kids.
Well, my